So first case is this 57-year-old woman, history of Roux and Y with abdominal pain. They all have Roux and Y and they all have abdominal pain. Let's see. So this is patient.
Ooh.
So interestingly, not much small bowel dilation. The colon has air and stool, but there's this little twist here.
Yeah.
And we have a lot of Roux and Y patients, and the surgeons here actually have low threshold for taking them to surgery. So this is thought to be a chronic internal hernia with volvulus of the root of the mesentery. We saw this swirl, a band that was tethering the ileocecal area to the left side of the abdomen. Somewhere here.
It looks like his SMV gets like super crushed in there.
Yeah, it does. Yeah.
Maybe, yeah, there's like edema in there. So maybe there was like some like early going towards ischemia or something, but.
Yeah, yeah. That's what, yeah, could have happened, although we don't see any changes in the small bowel here. All right, so next case is similar. This is a 31-year-old woman who had Roux and Y 10 years ago with abdominal pain. This is her scan. So this is less subtle because just diffuse small bowel edema and mesenteric edema and small bowel dilation, and also the vessels here converge, and leukodematous. So it looks like maybe there's a little opening here.
Is the bowel ischemic? I mean, it looks hypoenhancing.
Yeah, so the bowel unfortunately was ischemic, and they took this patient to the OR, reduced the internal hernia and detorsed that volvulus, and left the abdomen open to see if it was viable, but it was not. So on second surgery, unfortunately had to resect almost all the small bowel, and this person became short gut, which is an unfortunate common complication at our hospital. Usually they're referred here to get a small bowel transplant, so we see a large number of these, and when you review the outside imaging, often like this. Okay, third case, another 31-year-old woman with 3 days of abdominal pain. So this is her scan, so 3 days, sorry.
Victor, we have a quick question over here. Can you tell us more about small bowel transplantation? Because we don't do it, I don't think we do it here, but I'm not sure. Do you guys do it a lot?
There's a couple of surgeons here who do a fair number, and that's their specialty. Usually these patients need to get multi-visceral transplants, so it includes often a pancreas transplant, and they're here for months. And it can be successful, which is why they come here kind of as a last-ditch effort to save themselves from chronic TPN, but they're often immunosuppressed and can get other complications. So, let's see. All right. So this is that other. Sorry. So this is another Roux and Y patient who is 3 days post-op and has this scan. So you can see the Roux limb here is pretty dilated all the way to the JJ anastomosis. So that's what we described. So this patient went back to the OR and at this area, they found a kink. So this was lumen all dilated all the way, and there's kinking of the anastomosis, and the other bowel loops were decompressed. So case of kinking of the anastomosis. And then this fourth case is another Roux-en-Y patient who has left upper quadrant abdominal pain and has this scan. So what's the finding here? It's not subtle.
Like the excluded stomach is obstructed. Or
That's correct. Yes. And
yeah, like what a
Bowel's fine. The duo.
Sorry?
I think
Oh, the duo is abnormal too. Yeah.
like the excluded stomach is kinked here.
so
It's like a
there's
portion of the stomach or something.
basically obstruction here. And you can see there's some metallic clips are placed here and basically excluding decompression of this excluded stomach into the duo. And they went to surgery, and that's what they found. This was a gastric outlet obstruction, and because it was so distended, they had to resect this gastric remnant. But they found that these ninal clips placed during her gastric plication were abnormally close to the angularis, and this had resulted in an outflow obstruction to the remnant stomach at the angularis here. And so this patient had some GERD symptoms from this, and because this was so distended and ischemic, they had to kind of resect this remnant. Not something that we commonly see, but that's what this patient had. Okay, that is all I have.